Good afternoon, everyone. Hello, my name is Barbara Cannon, and I'm the Chief Operating Officer of NewCert Biopharma. And I apologize for the brief delay. We're just trying to get our audio all set up for you. As you know, please keep the speakers on mute until we have the opportunity for the Q&A session, as this entire presentation is being recorded. Again, it's a pleasure for me to welcome you to our virtual investigator meeting of NSWM01. I'd like to start off by introducing a couple key contributors to the protocol, our KOLs, Dr. Frank Greenway and Dr. Stephen Smith. Frank Greenway is an endocrinologist and directs outpatient research at the Pennington Biomedical Research Center. This center is focused on obesity and located on the campus of Louisiana State University in Baton Rouge, Louisiana. Dr. Greenway is on the editorial board of the International Journal of Obesity and has published over 150 peer-reviewed articles, over 30 book chapters, predominantly in the field of obesity, and holds several patents. His interest is in developing new treatments for obesity and has been active in clinical trials of candidate pharmaceuticals, dietary herbal supplements, medical foods, and devices. Pardon me. Stephen Smith is also an endocrinologist. His work bridges the gap between molecular biology and clinical care. Based in Tampa, Florida, at the Translational Research Institute for Metabolism and Diabetes, his work involves translating discoveries in the basic sciences into clinic and using clinical knowledge to direct the basic scientist. Dr. Smith's research is focused on obesity, diabetes, and the metabolic origins of cardiovascular disease. He is specifically focused on how individuals differ in their ability to adapt to diets high in fat and understanding how obesity leads to type 2 diabetes. Dr. Smith has published over more than 160 peer-reviewed scientific manuscripts, reviews, and/or chapters, and is active in medical education. Turning to our NewCert colleagues, I'm pleased to introduce a valuable member of our scientific advisory board and your medical monitor for this study, Dr. Orville Coulterman. Orville serves as adjunct professor at the University of California, San Diego Medical Center in the Division of Endocrinology and Metabolism. His prior work at Amylin Pharmaceuticals includes a wide contribution serving in numerous capacities as medical director, senior vice president of clinical and regulatory affairs, as well as senior vice president of research and development. Dr. Coulterman has authored numerous research publications and is a recipient of several honors and awards from the American Diabetes Association. He is currently serving as the principal investigator of the EPIC study, that's Epidemiology of Diabetes and Control, at UC San Diego. Most importantly, should you have any medical or clinical study questions, I know you will find Orville to be extremely knowledgeable, approachable, and a pleasure to interact with. Next up is another of our colleagues, Dr. Michael Zimmel, who you will be hearing from momentarily. Michael is NewCert's founder and chief scientific officer. Michael started NewCert in 2007, leaving the University of Tennessee to join the company full-time in 2012. He is a recognized expert in energy metabolism and endocrine, pharmacological, and nutritional modulation of chronic disease risk. He is the author of over 200 peer-reviewed publications, primarily in the regulation of fat cell metabolism and application of this research in the prevention and treatment of diabetes, obesity, and metabolic disease. Michael and NewCert holds an impressive intellectual property estate with a number of patents and regulation of energy metabolism and the coverage of new therapeutics for diabetes, obesity, and metabolic disease. Lastly, let me introduce Dr. Omar Flores. Omar has been your face of NewCert Biopharma, and he's responsible for the overall conduct of this obesity study. Dr. Flores holds a PhD in molecular and cellular pharmacology from the University of Miami and an MBA from the University of North Carolina, Chapel Hill. Omar brings a unique intersection of science and business. He was a Hoffman-LaRoche Fellow at Duke University, investigating the role of small RNAs in viral pathogenesis, and has authored 8 peer-reviewed publications and a recipient of an NIH predoctoral fellowship. I met Omar when he was recruited to Mountain Group Partners as a financial analyst. Mountain Group Partners is our lead investor group for NewCert Biopharma. And as I was setting up the clinical operations for NewCert, I quickly identified, or as my colleagues would say, I marked Omar's skill sets and eventually lured him from venture capital to R&D operations. You will find Omar to be very responsive, astute, and dedicated to make this clinical study a success for all parties. He will be visiting you again soon in 2018 and looks forward to sampling your local cuisine. So with that, I will turn this meeting over to Michael. Michael?
So this is Michael Zemmel, and hopefully you can see my slides. I'm going to go through them much faster than I had anticipated. Some of you may have seen a few of them when I thought I was being live audio, but apparently was not. So I'm going to just give you some high points. Our platform targets the enzymes that are nutrient sensors. They sense caloric restriction, and we activate these to recapitulate the benefits of caloric restriction, including reduced lipid storage and increased lipid oxidation. Our basic technology is built around the amino acid leucine, which enables the coactivation of SIRT1 by other activators, both SIRT1 and AMPK by other activators, such as metformin. And the result is a profound synergy, and we've demonstrated that clinically. Again, I'm zipping through these. Our integrated mechanism of action for the compounds that are in NS-WM-01 is shown in this slide, and that is leucine plus co-activating compounds recapitulate the effects of caloric restriction, recapitulate the effects of exercise, and oppose the effects of caloric excess. They do this by activating SIRT1, AMPK, and off on the right you'll see eNOS, endothelial nitric oxide synthase, which converges on and also co-activates SIRT1. The net effect is reduction in weight, but also improvement in multiple obesity-related comorbidities. We have a vasodilatory effect, drop in blood pressure, we improve insulin sensitivity, we reduce circulating lipids. We are going to be testing a combination of leucine and very low-dose sildenafil, and a combination of leucine, metformin, and very low-dose sildenafil. The leucine and metformin activate both SIRT1 and AMPK, mimicking the effects of energy restriction. Sildenafil you normally think of as a PDE5 inhibitor, and obviously it does that, but at much lower concentrations it's also an activator of the eNOS, or endothelial nitric oxide synthase system, leading to an increase in nitric oxide, which further activates SIRT1 or further recapitulates the benefits of caloric restriction. So that is the framework for what we're doing. Now the question is, how does it really work clinically? Well, overall, data to date show that activation of this pathway through our obesity platform results in a suppression of fat synthesis in fat tissue, coupled with an increase in fat utilization, fat oxidation, as well as mitochondrial biogenesis, or making new mitochondria, in skeletal muscle. So the net effect is transferring energy from storage in adipose tissue to burning in skeletal muscle. So to give you a sense of data to date, we ran a 16-week clinical trial, NS-0200-01, in which we compared 2 doses of NS-0200. NS-0200 is a combination of leucine, metformin, and low-dose sildenafil. And here we compared, we've already optimized the leucine and the metformin. Here we are comparing the effects of very low-dose sildenafil, 0.5 milligram, low-dose sildenafil, 1 milligram, in combination with leucine and metformin, and both, of course, compared to placebo. And what you see on this slide is a nice linear weight loss over 16 weeks in all subjects who completed the trial and adhered to the protocol. If we look at subgroups, you see comparable. Here we have individuals with elevated liver enzymes. So these were non-alcoholic fatty liver disease patients who were a little sicker, and you see that they had even a greater weight loss over 16 weeks. Again, it's fairly linear, no indication of a plateau. It's not just weight, it's also obesity-related comorbidities. So here we're showing you liver fat as an obesity comorbidity. And what you can see on the left-hand side is the absolute value, and on the right-hand side, the percent change. And what you can see is the high dose of NSO 200 caused about a 15% decrease in liver fat. Now, if we look at another slice of patients, here we're looking at patients that had elevated triglycerides, that is, using the standard clinical cutoff of 200, people who had triglycerides greater than 200 milligrams per deciliter. And what you see is, again, a somewhat linear weight loss with overall about a 5 kilogram weight loss over the course of the trial. This was accompanied by, as you see on the next slide, a very nice drop in serum triglycerides, nearly 150 milligram per deciliter drop in serum triglycerides with both doses of NSO 200. There was a tendency towards dose response, but really the two doses were equivalent to one another. Likewise, if we look at blood pressure, this particular slide, it shows obese subjects who were on antihypertensive meds at the time of the trial. But we get a comparable effect if we look at the full cohort. We get a comparable effect if we look at individuals who were hypertensive regardless of whether they were on meds or not. In fact, if we look at that group, we also show a very nice drop in systolic pressure. Here you see a nice drop in diastolic pressure. If you look at hypertensives regardless of medication, we get drops in both. Now, I'm going to turn to a little bit of preclinical data to help you understand why we're studying leucine sildenafil as well as leucine metformin sildenafil. We have studied this in a couple of trials preclinically, and in one trial, leucine sildenafil actually looks better than leucine metformin sildenafil, but in a recently completed, more comprehensive trial, what we see is that with very low dose sildenafil, the leucine sildenafil on the in the left-hand panel seems to outperform leucine metformin sildenafil. Here you're looking at weight loss in obese mice over 12 weeks. The black line is control, the blue line is leucine metformin sildenafil, and the purple, or whatever color that is, line is leucine sildenafil. If you look, however, at the right-hand panel, what you see is that when we boost the level of sildenafil up to a human equivalent of 4 milligrams, there we see that leucine metformin sildenafil looks equivalent to leucine sildenafil. Since we already have good clinical data on the triplet, we feel obligated to study both the doublet and the triplet in this study in this upcoming study. So just to give you a quick sense of how we've chosen our doses, again, we have spent a lot of time optimizing our leucine and metformin doses. Leucine we've optimized based on plasma leucine levels to get to a level that is sufficient to activate SIRT1 without any untoward effects. Metformin that is based on optimizing for insulin sensitivity based on work from a previous clinical trial. And for sildenafil, we are looking to activate endothelial nitric oxide synthase without inhibiting PDE5. And once you get north of about 5 milligrams, you begin to get some inhibition of PDE5. So we're trying to keep our dosage below that. So I've moved through this as quickly as I can, given our technical issues. Here's a quick summary. Leucine and sildenafil, with or without metformin, activates the signaling pathway that mimics caloric restriction. Clinically, we know that the triplet of leucine, metformin, sildenafil induces weight loss and improves obesity comorbidities without any caloric restriction. We have preclinical data to suggest that leucine sildenafil may be better than the triplet combination, but we don't have clinical data available on leucine sildenafil without metformin, and as a consequence, We are conducting this study to compare the doublet versus the triplet combination, as well as to optimize the dose of sildenafil used in either the doublet or the triplet. With that, I want to make sure we stay on task and on time given our long delay, but I can take a question or two if there are any. If not, we will progress.
Yeah. Okay, we have here, through many technological devices here, Dr. Orville Coulterman to go through the inclusion and exclusion criteria. Orville, can you go over the protocol highlights and the inclusion exclusion criteria?
Sure. Need to collect my thoughts after all this, concept is work. But basically, it's a parallel study, with 4 arms, looking to evaluate 2 combinations of leucine and sildenafil, 2 different doses of sildenafil, and then the same 2 arms repeated with the addition of a gram a day of metformin, given as 500 milligrams in the morning and 500 milligrams in the evening. The primary endpoint is the mean % weight loss for each group, and then there are a number of secondary endpoints. In terms of the inclusion exclusion criteria, subjects need to be over the age of 18, under the age of 65, or 65 or less at study entry. If female, they need to not be breastfeeding. They need to be postmenopausal or have a negative serum, pregnancy test, and then if they are childbearing potential, which include perimenopausal women who've had a menstrual period within the past year, you must be willing to practice appropriate birth control using a method that has a documented low failure rate. And the details of that are outlined in the protocol. Subjects should have a stable body weight, defined as plus or minus 5%, and no change in their health over the last 3 months. And this is based on medical history alone. Their BMI needs to be between 30 and 45. They should have a stable diet for the past 3 months, and no acknowledged plans to undertake drastic dietary modifications. If subjects are using antidepressants, excluding those that are called out in the exclusion criteria, they should have been on a stable dose